of course, I did promise we'd go through some of the things that might come up in the exam. Of course, no one knows for sure except for the college, but we do know that there are common themes that tend to come up again and again. So I've put together a list here of what are the things that I've noticed come up multiple times through not only the exam questions but practice exam questions. What are the things we're likely going to see? You're almost always guaranteed to get some kind of abnormal uterine bleeding, just one of those things that they're going to want to assess and know that you know something about. We spent a fair bit of time on Aboriginal and Torres Strait Islander health last week. We're going to go through a little bit of ethics and policy making, skin cancers, dermatology, ECG findings, mental health, emergency cases, your DRS ABCD, pediatrics, they're more than just little people, immunisations. I've said it so many times, I'm so sorry. As well as cough, shortness of breath, CCF, malignancy, and touch again on radiology. All right, let's kick off then with the first one here. For those that aren't familiar or don't have kind of backup mnemonic in place, palm cone is the one that I think is most helpful for people that may not be as familiar with abnormal uterine bleeding. Maybe you're a male in a practice that you don't see many female patients. This is something you should know. It's essentially a little mnemonic to try and get you to remember what are the structural, palm, and non-structural causes, cone. So most people can think of polyps, very, very common cause, adenomyosis, leiomyoma, which is the fancy name for fibroids, and of course malignancy, the one that we're going to be very, very mindful of. Non-structural causes could be coagulopathy, ovulatory causes, endometrial dysfunction, iatrogenic, so things like the Mirena or Implanon, for example, and of course the other not otherwise classified group. If this is something that you don't feel comfortable on, I would strongly encourage you to just read quickly through a brief update through each of these kind of topics and just become vaguely familiar with what are the things you're going to need to know. Really, that's going to be what is going to be most important to know for different age groups, different presentations, and to know as well a few questions that you can throw out. Oh boy, sorry guys. I want you to be able to throw out a few questions on ways to differentiate each of these conditions. I want you to be familiar with what the most recent guidelines are. There's some stuff that you'll find up on RACGP, other things that might come up tonight, topical, like a cream. And I want you to know probably the most important of all these things here is what are going to be the most appropriate first-line investigations. Often for these kinds of things, we don't necessarily get asked the second or tertiary investigations. What our job in general practice and primary care is often to do the screening to work out what are we dealing with and who do we need to get them engaged with for a lot of these issues, at least. Now, as I said, I don't want to go too much into Aboriginal and Torres Strait Islander inequity in healthcare. An incredibly common question or area to be explored in exams. I would strongly encourage you, if you haven't already, have a flick through last week's session. In particular, have a look at the teaching we did on the live stream as well as those individual cases that were put up. So if you're not familiar already and want to do some last minute cramming, there is a playlist on this channel that goes through each of the questions that I've done since I've started this whole thing. Now, ethics and policy making, it's frustrating because it's one of those things that I don't think is actually often taught in a lot of the programs, or at least there's not enough emphasis or focus put on it, and it is completely fair game in the actual exam itself. Have a think about what is your kind of structured fallback to handling an ethical dilemma. You know, who are the stakeholders? Who are the approachable, reportable bodies that you should be escalating to? What is a local policy regarding this? What is a wider area policy? What is a state or nation-based policy that you should be referencing? If you're looking for a bit of a framework to kind of build from, if this isn't something you've had a lot of exposure to, and admittedly, I don't think many registrars have probably had much experience in policy making for practices. The address I put up on here, and I will put into the show notes later on as well, actually goes into different blank templates that you can build up for your practice, but it's also a fantastic resource to have a look at and get that prompt for lack of a better term, of what are the things they're actually looking for when you're putting together policies. What are the things they're going to be assessing for? Now, skin cancer and dermatology. One of the things that I think mucks up a lot of people and people lose marks on is just know the relevant margins for lesion excisions. And if you haven't already, have a good read through of the DermNet image library. Read through, it's the wrong term. Look, glance. Flashcards. Most of the questions that you'll get for the exam for dermatology. Oh, I'm leaking from everything tonight. Sorry, guys. Sometimes life just throws you curveballs. Life just likes to knock you down and say, stay. But we will not. We will rise. We will continue. We will push on. And as they say, the show must go on. DermNet have a little image library that you can actually just click onto and scroll through different images. And if you can't look at some of those things and quickly say, oh, I reckon that's this, or oh, I think I know what's going on here, click through and it'll bring up that condition and a bit of a spiel about that. That is by far, particularly given we only have a very limited time left, the easiest way to get very good at the dermatology questions. And surprise, surprise, some of those images might look very familiar in the exams. There's not many massive databases of readily accessible dermatology cases to pull from. And so, of course, the college is going to be pulling from DermNet. So if you want that little bit of potentially an advantage to have that kind of sneak peek of what material could be used, fantastic and underutilized resource. Also, very important to, because they kind of cover multiple domains by looking at rashes and pediatrics, just be familiar with what are the common childhood rashes, how would you differentiate between them for history and clinical examination, and what is a basic approach to each. It's either watch and wait, topical steroids, emollients, or antifungals. That tends to be the rough rule of thumb. Maybe biopsy, less so on kids. All right, ECG findings. I love ECGs. I don't know, something about them I just nerd out over. I worked in ED for a long period of time, and I guess maybe that's put a bit of a love in there for me. This is a consultant level exam, but they also acknowledge that the quality of the images may not be fantastic. Very difficult to kind of be able to print these things on scale. And so they're not going to try and trip you up. They're not going to try and give you something overly difficult. Be very comfortable in identifying atrial fibrillation, atrial flutter, heart blocks. In particular, I'd say third degree heart blocks is a good one to know off the back of your hand. It is one that's, for better or worse, is actually disturbingly easy to miss if you're not specifically looking for it. It goes back to make sure you've got that structured approach to ECG interpretation. You know, look at your P waves, look at your QRS, look at your intervals, look at the relationship between the P and the QRS. And I think if you're doing that basic kind of count, that basic look, you're going to be just fine. Of course, you're going to want to know how to identify a STEMI. Bonus points if you can localize the STEMI, but if in doubt, feel free to just specify that it is a ST elevation myocardial infarction. You'll get marks there. Acute, extra marks. And again, if you add that localization, extra marks again. And another area that seems to pop up again and again, and everything I'm covering here, I'm not giving away any secrets. A lot of this is pulled from exam reports as well. Just covering my own backside with that one there as well. Adverse drug effects. We're often informed to monitor for ECG changes, and surprise, surprise, that's examinable content. So if you do come across a question that you're looking at an ECG and you're thinking, that looks really weird, I have no idea what's going on, but I know there's something abnormal, and there is maybe an emphasis or a particular placement of a medication in there that you know potentially has those ECG effects, feel free to take that punt and say, toxicity due to or ECG changes consistent with. Mental health. Something that I think is a GP's absolute bread and butter. We do this every day, day in, day out, which actually sometimes makes it tricky because we can see a patient, look at the facts and instantly say, okay, I know what's going on here. sometimes we might be a little bit more forgetful to have a look at specific diagnostic criteria. And something that frequently comes up on these timelines is actually looking at the timelines involved to meet specific diagnoses. That will often come up in the form of either a patient presents with symptoms for a period of time, what is the diagnosis, and that time frame may change the specific diagnosis, or it could be the other way around of what further questions would you have where you have to ask, are your symptoms over X duration to meet certain criteria? Likewise, it's going to be the salient positive findings for a diagnosis and the salient negative findings. Remember, for all these mental health diagnosis criteria, easy marks, if you get stuck for nothing else, is going to be that diagnosis that is not consistent with any other diagnosis or due to substances to throw away there. And they want you to also have a feel for what are the risk factors for common conditions, your depression, your anxiety, bipolar disorder, those kinds of things. I'm going to duck back for a second because, as Demira's popped up on here, your QT intervals and hyperkalemia, yeah, it's always going to come up. So, again, very good things to know. Thanks very much for that. All right, moving on then. Emergency cases. Your DRS ABCD. That's a mnemonic that I still use to this day and has saved my butt countless times. I think everyone should keep this one in their back pocket. If you're ever caught in a situation where you feel like you're experiencing anal flutter, DRS ABCD, check for dangers, check for response, send for help, airway, breathing, circulation, defibrillation or disability. Chef kiss. It's going to do you until help arrives or you get that flash of inspiration that lets you know what direction you should be heading in. Now, something that the college also loves is adrenaline. The first line management for anaphylaxis is adrenaline. The second line management for anaphylaxis is adrenaline. The third line management. Good marks to know adrenaline. It's one of the few times you may actually be asked for dosing, knowing that 0.5 is your appropriate dose for IM adrenaline in anaphylaxis has been a question. In a lot of the study material that I've gone through, and I think would be a very fair game thing that we should know off the back of our heads. You should also remember that ask for help component, and an easy thing to remember is often they'll specify you're working in a rural setting, and so often that means actually sending them to St. Elsewhere's, organising that transfer to a higher acuity care. This is examinations based at general practice, acknowledging that many people are going to work in urban centres and may never work in ED, but they want to prepare you in case you're locuming in a rural location where you may be the only doctor in that entire town or region. You need to know how to respond to an emergency situation. And tied into that as well, something that we often forget, or it may just be that something we would do without even thinking about it, for management of emergencies, often IV cannulation is worth an easy mark. And of course, don't forget for all emergencies, there's going to be that continuous ongoing monitoring to assess for changes. Again, nice easy mark, but you can't think of other things there. Okay, coming up to paediatrics. There's often a bit of a focus, again going through all the exam reports, on common ENT or respiratory conditions. And if you're unaware or haven't checked, be aware that there were changes to the management of otitis in general practice setting for Indigenous children, taking into account the fact that a lot of Indigenous children do live in urban settings that they don't have the other risk factors that more rural or remote communities may have, and so non-antibiotic management may actually be more appropriate in that setting. So again, if you're not familiar with that, I'd go through those guidelines and just re-familiarise yourself quickly. It should only take 5 minutes. As we said before, know those common paediatric rashes because it's an easy way for them to assess multiple domains in one go by throwing out a rash in a child, have a good idea of what those early childhood rashes could be, and immunisations. Yeah, sorry. As I've said from day one, it's just one of those things you really just have to kind of go and memorise, for lack of a better term. You've got your COVID immunisations, your influenza immunisations to kind of fall back to if you really get stuck, but you really should have a decent working knowledge of what the immunisation schedule is. Again, just going to duck back for a second. To me, you've popped in here milestones. Yes, yeah, you will find in a lot of situations milestones can be one of those things that does get assessed. It's often only worth kind of 1 mark. I would be surprised if they have what are the milestones for this age. It's normally are they meeting milestones for this age. But yeah, definitely you should have a ballpark idea. I think some of us are lucky in that we have children in these age groups. If not, try and think back to when your children were in those age groups. And if you don't have children, sleep must be amazing. But it's probably worth just having a quick flick through what are the milestones for different age groups. All right, something very dear to my heart at the moment. Investigations and management of cough, shortness of breath, congestive cardiac disease, or lung malignancy. You will often have that undifferentiated cough or investigation and try and have a bit of a structured approach or fallback kind of idea of how you approach these things. Know your first line and second line investigations for each of these conditions and when each might be more appropriate than others. And please read the qualifier. So most common is going to be your simple diagnoses, the common cold, for example. Most important is going to be your malignancy type diagnoses. First line is going to be your plain X-ray, not your CT, high resolution CT chest. Those little qualifiers can make all the difference in the world. So try not to fall for those little traps. Try and pick up on those early, and it'll do you a world of good. Radiology. Now, there can be radiology questions being asked, and often I think it's actually probably easier questions than what other image-based questions could be. Again, try and think back to your med school days. Really go back to some of those fundamental basics, checking the patient name, checking the patient age or details there, checking the date of the scan. I will put my hand up and say I once was guilty of misdiagnosing a case because I looked at an X-ray, made a call of what I saw, didn't realise that the X-ray I was looking at was the correct patient, but was taken on the exact same date 1 year prior to the day, and I was looking at thinking this was today's X-ray, and I had not realised they hadn't uploaded the newest X-ray. I just saw the day and the month, always check the year, and that was something I'll never live down. No harm came to the patient or anything like that. I just looked like a massive idiot. Now, something that does come up again and again and again is just know some of your common findings for common things. And one of the easy things is know your findings for osteoarthritis and rheumatoid arthritis and how to differentiate between the two. It's going to be those non-uniform joint space loss, osteophyte formation, cyst formation, subchondral sclerosis, or marginal erosion, soft tissue swelling, symmetry, osteopenia or porosis for your rheumatoid arthritis. For all these pictures, similar to the ECGs, they're unlikely to be of great quality, which can actually work in your favour. You're probably not going to get those subtle findings. You're going to get those big shout out loud kind of diagnoses. It's not going to be a subtle possible fracture. That bone's going to be obliterated. And so as long as you don't spend too much time kind of staring at the fine details on the print, I think you should be just fine. All right, finally I want to talk about the final 10 minutes. I'd say 10 minutes, it could be 15, could be 20. Set a space of time at the end of the exam that you feel comfortable with, that you think you can realistically achieve, and have a plan for how you're going to use that time. I think that for people that leave early in the KFP, if that's your thing, you don't want to be sitting there second guessing yourself, that's fine. Do you. But I think you have a valuable opportunity to read through your answers and do that bit of screening. Again, I don't think it's your knowledge, your clinical knowledge, that sets most people back in this exam. It's the exam technique. It's the losing the marks from overcoding that mucks most people up. Number one, check the number of answers for each question. Make sure that matches the requested number. If you have not given enough answers, you're missing out on marks that you can add an answer to it. if you've answered too many questions, you're going to miss out on marks. You're going to lose that 0.25% of the overall score. And I know it doesn't sound much, but geez, does it add up quickly? That's going to be that element of overcoding. Likewise, have a read through each line. You should have one answer per line. So there are no ifs, ands, or buts. Make sure that you're not actually subtly giving two responses with one answer. That will be overcoding. You will lose the marks. Again, no abbreviations. Look for any and all abbreviations, cross them out and spell it out over the top of it. Make sure you don't fall for that trap. Yes, it's clinicians marking these exams, and there is a little bit of leeway where they may decide to give you marks based off of an abbreviation, but the official line from the college about abbreviations is just don't do it. Finally, if you've done all those things and still have a bit of time free, just make sure you've got that diversity in your answers. Make sure you're not falling for the grouping trap and that you're not actually giving the same answer just in slightly different ways multiple times. So if they are grouped, remember you only get the marks for the first response, and so make sure that you're having that diversity there to make sure you're catching as many answers as possible. Now, we've spent a fair bit of time on this bit of teaching tonight. I really wanted to get to this while we have that final opportunity to do it before, more practice questions before the exam. These are the things that should be fresh in your mind going into the exam, that you've got that plan of attack moving forward. Hopefully it's helped.